it is my pleasure to introduce this webinar in the systemic treatment in bone sarcoma on behalf of Cellnet. I'm really excited, not only because there are new drugs in several bone aggressive and indolent, more indolent sarcoma, but also because these meetings strengthen our community. And I discussed with a patient yesterday with a sacrum B-core PATS1, no, AGFR PATS1 of the sacrum from, no, of the neck from Buenos Aires. I just wanted to tell you that these aggressive and rare diseases are very increasing through molecular sequencing, and being in this community will definitely be a great support. And Javier knows very well how we talk, and I will be very happy to talk to you. But let's go into the program, the Emerging Treatment in Bone Tumor by Dr. Marco Zapata from Colombia.
Okay, I will share the screen. It's okay? Did you see my?
Yeah.
Okay. It's in full screen?
Not yet.
No,
Okay.
not yet.
Not yet, but wait, now. Okay. Thank you to be here with us. Good morning, good afternoon. Now
sorry, it's not in presentation mode.
No
if you want to.
Okay, I will reshare the screen.
But, or
now,
maybe it's a technique.
Now.
Oh, yeah, now, yeah, perfect.
Yeah, okay.
Please.
Okay, good morning, good afternoon. Now I will address the emerging data of innovative systemic option in advanced osteosarcoma. And this is my disclosure. If we look back to 1970s, when multi-target chemotherapy was introduced in osteosarcoma, it was revolutionary, because before that, the 2-year survival even in localized osteosarcoma is around 20%. With the multi-target chemotherapy, it increased to 70%. 10 years before the introduction of perioperative chemotherapy in breast cancer, this was revolutionary. Unfortunately, after that, no another chemotherapy shows any advantage in advanced osteosarcoma. In the last 2 decades, the use of multi-target TKI was introduced with benefiting around PFS on around 6 months. And now, if you look the NCC guidelines, the use of chemotherapy or TKI, the choice of between them is because the patient performance status, the patient preference, the access, but not by tumoral response, okay? If remember, osteosarcoma have defects in DNA repair, but mainly in a chromosomal landscape. Not if we can see, for example, HDR mutation, but we don't have a clear marker, for example, BRCA phenotype. Last year at ASCO, the combination of olaparib and ATR inhibitor showed a scare benefit in response. How to select the correct osteosarcoma that had this BRCA phenotype? We don't know. In breast cancer, for example, looking the effector of HDR process, RAD51, when it's lost by immunofluorescence, all the patients with breast cancer had pathologic complete response. How to translate that from another tumor that have some kind of HDR mutation? We don't know yet. As you know, p53 and retinoblastoma is often mutated in osteosarcoma, germinal or somatic. Preclinical data show some kind of response, for example, with CDK4 models, but today maybe is the combination with everolimus or another PAM pathway inhibitors that could be an option in clinical trials. Talking about immunotherapy, remember, osteosarcoma, again, is a highly mutated tumor, but it's not classic mutated that produce new antigens. If you look the TMB in osteosarcoma, it's often low TMB. But another side, if you look the tumor microenvironment in osteosarcoma, it's not the same as the classical adaptive immune resistance with higher CD8 plus lymphocytes, high expression of PD-L1. Osteosarcoma have expression of PD-L1, maybe oncogenic driver, but the microenvironment is more represented by M1, macrophages inhibitors principally, okay? Data for the Pembro-SARC trial show a little response in only one patient, less than 50% of response in this trial. Maybe the future is to include therapy that could be address more than one receptor. For example, this one that inhibit the expression of PD-L1, also the CSF1R depleting or modify the M2-like macrophages, and also the addition of anti-angiogenic. This approach shows benefit in around 66% of PFS at 3 months. But the landscape in oncology in general is changing. This is the osteosarcoma sulfosoma. The expression of molecules that not only is oncogenic driver receptor, is the importance of this receptor is to be present in homogeneously in the tumor. CAR-T osteosarcoma was developed in 2 ways, EGFR and HER2. In this pediatric trial, when around 25% of the patients were osteosarcoma, showed some kind of response with CAR-T against EGFR. And in the HER2 trial, with mainly osteosarcoma, some kind of patient had overall survival more than 2 years. But one of the more revolutionary area in oncology is the ADC design and development. Remember, osteosarcoma is a highly depends of high dose of chemotherapy, but when you pass from 3 drugs to 4 drugs, only only improve in a little. But with ADC, with antibody that is more specific to the tumor, with linker that is more stable, and with high potent drug, we can deliver in around 400 times more concentration of the drugs at the tumoral tissue. The last year at ESMO, Artemis 002 were present. This is a phase 2 trial from the people of the China. In the cohort of osteosarcoma, we saw in first time in this kind of tumor, not only a deep response, but the duration of response was around 90 months. This in late lines in osteosarcoma, it had never been described, okay? And for the initial report of PFS and OS, the PFS is around 9 or 3 months in the medium, and the OS no reached, the median OS no reached. But finally, what is the problem in osteosarcoma? In osteosarcoma, we're still looking for the response. In this patient, that was treated with chemotherapy, this is the image before and after chemotherapy. But if we perform, for example, a PET-CT scan, you look at the viability of the tumor, is less. But can we improve the evaluation of the response in osteosarcoma? Maybe yes. The group of the MD Anderson in 2020 in a predominant osteoblastic tumors used the radium-223 for metastatic osteosarcoma and had some kind of response. That's why the NCC guidelines include radium-223 in these subtypes of tumor with highly predominant osteoblastic lesions. But now, if we market, we label anti-GD2 antibody for radiopharmaceutical imaging in this murine model, we have more specific images that show viability of osteosarcoma. And this will be translated with, for example, luteation or actinium has happened, for example, in prostate cancer. In conclusion, systemic treatment in osteosarcoma in 2026 is still with conventional chemotherapy and multi-target TKI. Yes, we have emerging data in cycling targets or HRD target maybe will be important in combination to prevent, for example, resistance to conventional treatment. The immune system in osteosarcoma is quite complex than the other tumors. And maybe the manipulation of the TME microenvironment will be more important than, for example, only use the PD-L1 or PD-1 blockade. ADC in osteosarcoma, good news, maybe because we can use more chemotherapy and more concentration in the tumor. The therapeutic in osteosarcoma, we have better diagnosis in metastatic disease, better ways to define the response of the disease, and also use the target to deliver, for example, the radiopharmaceuticals. But until now, remember, we are talking about Latin America. At my center, 70% of osteosarcoma present with metastatic disease. It's contrary that happened, for example, in Europe. And the time from symptoms to diagnosis is around 6 months. Maybe in Latin America, we must improve this one to use this kind of drugs better in curative intent more than in metastatic disease. Thank you.
Thank you. Very nice presentation. Should we do the question now or at the end?
At the end, or maybe the agenda is at the end, but I don't have problem if you want to ask me now.
Hello, Emmanuel and everybody. I think that questions should be better at the end because maybe some of them will be answered during the rest of the presentations, or as this is only osteosarcoma, sorry, I think that all the questions will be better at the end. Okay?
Okay.
So we'll do it at the end. So we move forward with Andres Rodriguez from Instituto Alexander Fleming with the Ewing sarcoma promises in advanced disease. Hello, Andres, and hello to everybody. Sorry, I get in late. I'm sorry about that.
Thank you so much for the invitation. You can see my presentation.
Yes.
Yes.
But it's
Thank
not
you.
presentation mode, Andres. Maybe you have to share again.
Okay.
The full screen and share. Full screen.
Now you can see my presentation.
Perfect.
Yes.
Please.
Okay. Thank you for letting me share this brief presentation about Ewing sarcoma promise in advanced disease. This is my disclosure. This is the agenda. For being more quickly, all of you know that Ewing sarcoma is the second most common primary bone tumor in children and teenagers. And majority arise in bone, but 50% arise in soft tissues. And the location more frequently in chest wall and pelvis. The median age is 15 years, and this is a chemosensitive disease with characteristic immunohistochemistry and morphology. CD99 and NKX2.2 are characteristic immunohistochemistry, and of course the specific rearrangement in EDWH receptor. And you know that others small round blue cells tumors have another fusion that be important in prognosis, like sick ducts and PCORs with bad prognosis, and PAX1 hem fusion for good behavior. This is the standard of care scheme, and we learned from several clinical trials conducted years ago that the backbone is BDC, IE scheme every 14 days in 7 cycles, the logistic with perioperative treatment for localized disease and metastatic disease if the surgery is possible, but if this is not possible, radiotherapy you can use, and of course both strategies if the surgery is R1 or R2. And don't forget the worst survival if you delayed the local treatment more than 16 weeks after neoadjuvant chemotherapy. In metastatic setting, there are retrospective evidence to that local therapy and metastasis therapy can be improved survival if you use, for example, radiotherapy in metastatic sites besides the local therapy with surgery or radiotherapy. Recurrent and relapsed Ewing sarcoma have long-term survival that is poor. There are multiple regimens used at progression, but there is no standard of care, and there is no more effective therapy than chemotherapy. Outcomes depend if we talk about local recurrence or metastatic disease or both. All of you recognize this international trial, RECUR, that have a design of MAMS and drop a laser arms, start for 4 arms with 4 chemotherapy schemes, and this was dropped if it don't have benefits. Now we know that ifosfamide high dose ifosfamide have the better perform with a PFS about 5.7 months. And nowadays, with adaptive Bayesian design, analysis adjusted to improve precision in phase 3 design with no inferiority at 2 arms with ifosfamide, lenvatinib, and trabectedin irinotecan. Now move to systematic reviews. They say that include phase 1 and 2 trials between 2005 and 2018, that there are some limitations. No new therapy changes standard of care. The limitation is about the majority of this study use monotherapy. There are no randomized trials, and there are population heterogeneity. Of course, lack of clear biomarkers. The majority of these clinical trials, the primary endpoint was response rate, around 70%. And this is a problem because stable disease predominating. The recommendation of the systematic review is to use PFS as primary endpoint in phase 2 trial, and of course, introduce collaborative platform. More recently, the Ewing consortiums make a systematic review that includes phase 1 and 2 trials in a period of 2014 and 2024, major of that for United States an initiative academic trial, and more of them have a target therapy followed by immunotherapy. And the limitation was the same. Response rate is the most common primary endpoint, and there are high variability trial designs. Let's move to talk about molecular prognostic factors. The genomic landscape in Ewing sarcoma show us that this disease have low mutation burden. There are no biomarkers for immunotherapy. There are two subgroups, STAC2 mutation and TP53 mutation that have poor prognosis but not currently druggable. Now, therapeutic targets under study. There are new therapeutic targets, but no results superior to conventional chemotherapy. The example of that is IGFR, that there are many clinical trials around this target, many drugs, but not improve the survival. PARP was identified as potential therapeutic target in Ewing sarcoma because this is a transcriptional regulator of the EWH fusion, but as single agent, the results was disappointing and increased the interest with combined with chemotherapy. There are examples of that. Take account the cytotoxic combination associated with significant toxicity that limited the dose. Recently, phase 1 and 2 include olaparib and irinotecan, shows in 36 Ewing sarcoma overall response rate around 9%. For another hand, the EWH fusion cause replication stress and ARC loop accumulation. That way, ataxia-telangiectasia pathway was activated and increased the interest to combine inhibition of PARP and ATR. The TKA have interest in this disease, and there are some phase 1 and 2 trials with monotherapy. As you know, regorafenib, cabozantinib, lenvatinib, pazopanib, and that showed a median PFS around 3 to 4 months with very low response rate. When you use combine with chemotherapy, Gaspar in the publication of 2024 show us lenvatinib plus ifosfamide and etoposide that don't reach the primary endpoint PFS statistically, and overall survival was not different with compared both with chemotherapy, and the toxicity increased with we add lenvatinib. This interesting molecule, TK216, binds and disrupts the binding of EWH fusion and RNA helicase. And there are some synergistic activity with vincristine. In phase 1 and 2 study, results showed in ASCO 2021 that response rate is around 5 to 9.7%, take account the cohort expansion. But the median PFS was very low, 2 months. For that reason, studies continues to understand and identify better biomarker and consideration for other rational combination. Another interesting target is this epigenetic regulator, LSD1, that have reversal of transcriptional activity in the EWH fusion. The phase 1 trial show us some activity, and phase 2 and phase 1B combination with chemotherapy is currently ongoing. Recently, publication about the combination of trabectedin and low dose of irinotecan as a target to AWH fusion, because trabectedin have reverse activity of this fusion, and this is potentiated by low dose irinotecan in vivo. And this combination have an overall response rate about 33%, and PFS in 6 months about 48%. And here you can see the ctDNA as biomarker in clearance statistically significant. And finally, CAR T-cell targeting emerging neoepitopes like GD2, EGFR, and a member of B7 family that shows activity in preclinical studies, and now there are some ongoing clinical trials about that. In conclusion, the developing of new targets remain challenged in Ewing sarcoma. Understand the biology and microenvironment is bringing promising data to early phase clinical trials. MAMS and basket trials offer new possibilities and are generating exciting and early data. Take account some limitations that we learn. Evaluate combinations, use PFS as primary endpoint, and include biomarkers. Thank you so much.
Thank you very much, Andres. So now, Emanuela, do you want to say something?
Yes, I just wanted to present the next speaker. We will go now to female presenter. I'm pleased to introduce Bruna David for the Instituto Nacional de Câncer in Brazil. And she will discuss about chondrosarcoma. Do we finally have any option for this patient? Thank you.
Thank you, Manuela. Hello, everyone. Good morning, good afternoon. It's a pleasure to be here. I am Bruna from Brazil, and we are talking about right now of novelties in chondrosarcomas. We had this kind of talk last year after CTOS. We have many improvements for this disease from the last years. Isabel, you are sharing my slides? Yes, thank you. So these are my disclosures. Next, please. Just a quick introduction about chondrosarcomas. We are talking about a heterogeneous malignant bone tumor. It's a group of different subtypes. They come from cartilaginous matrix, and they correspond of about 20% of primary bone tumors. The conventional group is the most common subtype. They encompass grade 1, 2, and 3 regarding the aggressiveness, and also non-conventional subtypes encompassing clear cell, mesenchymal, and the differentiated chondro. We know that tumor microenvironment elucidation in the last years are becoming more clear for us, and due to that, I have this talk today. Next, please. So starting with the conventional chondrosarcomas, we know that the base of treatment for localized disease is the complete surgical resection. But when the disease is unresectable or metastatic, we have few effective options. We know that the disease is chemo-radio resistant, so it's very difficult to see a conventional chondrosarcoma responding to conventional chemotherapy, but we do try because we don't have many options for these tumors, and since we just don't have targeted systemic therapy until now. They have very poor prognosis, for instance, without any treatment around 2 months when the disease is metastatic. And when we add chemotherapy, a median PFS around 2 to 3.6 months. With TKI is a bit better, around 4 months, but still a dismal prognosis. Next, please. So starting to talk about TKIs in chondrosarcomas, we have a trial that evaluated pazopanib. Pazopanib is a very well-known drug for sarcomas. It's a multikinase inhibitor. It was a phase 2 trial, a multi-center trial encompassing 47 patients with just conventional chondrosarcoma. We saw that one patient had a resistant response, but most of the patients stayed with stable disease, with a median progression-free survival of about 80 months. So it's a drug that we do use for conventional chondrosarcoma, especially for the low-grade subtypes. Next. The second TKI formally tested for chondro was regorafenib. Here we have also phase 2 multicenter trial encompassing 24 patients, but here with different chondrosarcoma subtypes, not just conventional. Here we saw 2 patients with resistant response, and most of the patients remained with stable disease when they did not progress. The median progression-free survival here was around 4 months, and with 2 different patients with a long-term treatment, but they are, of course, exceptions. We don't see commonly patients doing this long duration of treatment with regorafenib. And it's important to highlight that it's a very toxic drug, so sometimes difficult to manage the treatment for long term. Next. When it comes to non-conventional chondrosarcoma, just a quick observation about mesenchymal. We know that they are very responsive to chemotherapy used to do in the context of localized or metastatic disease. Even sarcoma-based regimens. But we are not talking about mesenchymal chondrosarcomas today. I want to focus here in the differentiated chondrosarcomas. We know data from retrospective trials that they are kind of sensitive to cytotoxic chemotherapy used to combine chemo and surgical therapy when you have a localized disease. But for metastatic disease, we do osteosarcoma-like regimens or sometimes doxorubicin for those patients, but still we have a median PFS of around 4 months. And you know that even if they are in this context, the most responsive to cytotoxic chemotherapy is still the prognosis is very, very poor. Next. So in this context of very few systemic treatments and understanding better the tumor microenvironment and biology, we are trying to escape from the cytotoxic and tumor and blood flow, let's say, systemic treatments to understand better if molecular targets could help in those treatments. So Nadia will talk about the IDH mutated tumors, so I'll skip this topic right now. I'll focus on the death receptor 5 agonist and immunomodulation in chondrosarcomas, very new data and very exciting data also. Next. Starting with immunotherapy, when you're talking about immunotherapy in chondrosarcomas, we are mainly talking about the differentiated chondrosarcomas. I would like to start with the IMMUNOCERT-2 trial. It was a continuation of the IMMUNOCERT-1 master trial that encompassed the many subtypes of sarcomas, being evaluated for the combination of sunitinib, another TKI very well known, and the combination of sunitinib and nivolumab. And those patients were evaluated in a very broad spectrum, and we saw that this cohort of the differentiated chondrosarcoma had a very interesting response in the very beginning of the trial. So second cohort was evaluated, encompassing 24 patients from 7 centers. And we saw that the combination was feasible with the minimal toxicity. We have here the mentors of the trial, so can also ask more detailed questions further. And the point here is that we saw a very interesting response rate of after 6 months, around 46% of patients with a progression-free disease. And also the median PFS for the entire cohort was 5.6 months, is again a very manageable toxicity profile. Next, please. Similar to that, we have also combination of anlotinib and other TKI and anti-PD-1 therapies. Here we have just Chinese patients. It's a Chinese trial. 90% of the patients use tislelizumab and other 10% pembrolizumab, but still the same rationale for the combination. It's very important to say that the differentiated chondrosarcoma, they have the hotter tumor microenvironment in the entire subtypes of chondrosarcoma. That's why it's interesting to evaluate immunotherapy in these subtypes of sarcomas. Here they included the conventional chondrosarcoma and also the differentiated chondrosarcomas. And you saw that a very discrete response for the cohort of conventional chondrosarcoma, but for the cohort of the differentiated chondrosarcoma, we have a median PFS of 7 months for the combination in comparison to 3.8 in the unlotinib alone subgroup. And also the partial response was almost 30% for the combination, with 30% of patients achieving complete response instead of non-response from the cohort with the lotinib when the differentiated chondrosarcoma was evaluated. Very nicely to say that all patients positive for PD-L1 or patients from the differentiated chondrosarcoma subgroup, and all patients in some kind of response harbored mutations in IDH1 or 2. Which means that maybe the combination of targeted therapies can add also more benefits. We just need to understand if it makes sense, and also, and of course, the safety of these kind of combinations. Next, please. And changing a bit about targeted therapy, we're talking about now DR5 agonists. They are not new. We know them for a long time. It's important to understand the pathway of activity. We know that they skip the tumor proliferation role, and they do not need the classic achieving the tumor with the blood flow. They directly engage the apoptotic pathway by connecting DR5 receptor, by the activation of DR5 receptors, and TNF related to apoptosis induced the ligand, the trail. And this connection triggers formation of the disc complex, and this activation reascends the multiple downstream caspases, and it starts directly the apoptosis complex of the cell microenvironment. So as I said before, for a long time they have been studied, but due to this connection with the trail ligands presented also by normal organs, especially liver, the toxicity was a very big concern, and that's why those drugs were not used in practice, because they were very, very toxic. And more recently, we have in BRICS 109 that was, next Isabel, please, that was developed especially for cancer cells, next please, for cancer cells ligands. And it's very interesting to say that it is very specific, so the toxic profile is very, very manageable. Next. So we have this phase 1 trial to understand the safety profile of this drug. And we saw that the drug was very well tolerated with a rate of grade 3 events around 5%. And the single agent activity was very impressive with a median PFS of 7.6 months in a phase 1 trial. And it was regardless of the IDH1 and 2 mutation status. So due to that results, we have, next please, we have the design of a phase 2 trial comparing Zekibart, formerly called in BRICS 109, versus placebo. Patients with just conventional chondrosarcoma were randomized in 2:1 model to receive ozekibart or placebo. The crossover was permitted. Next. And we saw that the progression-free survival here was very impressive. We just ozekibart here, 5.5 months versus 2.6 months for placebo. Next. And the benefit was regardless of the IDH1 mutation status, and also regardless of the histological grade. Also, the high-grade tumors as grade 3 were responsive to the drug. Next. Regarding toxicity, it's always important to highlight that it was a very well-tolerated drug. The most common factor for the liver was the elevation of ALT and AST. And the mitigation program was implemented from the very beginning with the control of lab exams, especially to liver enzymes from the first cycle. And we saw that the response rate was very impressive, and also the toxic profile was very manageable with this mitigation program. Next. So just to summarize, I'm giving here some spoiler from Nadia's talk, but it's impossible to give this talk without talking about IDH. But yes, we are seeing a very, very nice evolution of the chondrosarcoma treatment from common TKIs to more targeted drugs in the past years, especially immunotherapy for the differentiated chondrosarcomas. And next, to conclude, the other colleagues already said it's very important to understand the tumor microenvironment and biology to develop new drugs. But more than that, I think that the most important message is that it's possible to conduct trials focused on specific histology and molecular-driven, especially for rare diseases, since one size does not fit all, and we that treat sarcoma know that very well. So I would like to thank you for the opportunity, and I'm open for questions later.
Thank you. So the last speaker, it's a pleasure to introduce Nadia Indi. Nadia will present on another space on the conventional chondrosarcoma, IDH inhibitors as a new therapeutic opportunity for an unmet need. Thank you, Nadia.
Thank you, Manuela, for the introduction. Good evening. Well, evening, no, afternoon, morning. Can you see my slides in presentation mode?
Yes, perfect.
Okay, so the next 10 minutes I will share with you another therapeutic option for chondrosarcoma patients. These last years have been good news for this orphan disease. So lately we have several promising therapies, and in detail, this is a therapeutic option that is already being developed. A clinical trial is ongoing, and we wanted today to share with you the possibility of including your patients in this study, because right now is one of the few trials available for chondrosarcoma patients. So we thought it was important to share it with you. These are my disclosures. So I'm not going to repeat what Bruna already said. Conventional chondrosarcomas is, as you know, the most common subtype, and only conventional and differentiated chondrosarcomas are known to harbor IDH mutations. IDH mutations are more frequent in the DIF chondrosarcomas. In some series, the presence of the mutation achieves even 80%, but we know overall around half of the patients with conventional chondrosarcoma have a tumor with IDH mutations. This can be found more often with a higher grade. And we don't know, the prognostic impact of having this mutation is not clear yet because there are some contradictory data. But what we know is that this is a predictive factor and for response for these drugs, and very interesting therapeutic targets. Why IDH is involved in tumorigenesis? IDH, as you know, is part of the metabolism of the cells and acts in the transformation of these substances, that when in the presence of a mutation of EDH, there is an accumulation of this substance in the cell, which is involved in several processes that lead to tumorigenesis, such as DNA repair and methylation, the increase in reactive oxygen substance. It's able to change or modify the microenvironment and the cell, making more prone to tumorigenesis. So there are several mechanisms, but all of them lead to an increased risk of creating a tumor. So it was, of course, an interesting target to be explored, and several IDH inhibitors have been developed, but the data that we have more mature is those coming from ivosidenib. Ivosidenib is a drug which is oral and is taken once a day. It's already used in other solid tumors, and specifically in chondrosarcoma, we have the data coming from the phase 1 study. In this study, 13 patients with advanced chondrosarcoma were included, and as you can see here in the swimmer's plot and in the waterfall plot, there were some patients achieving an objective response, 23% of the patients, which is more than we have seen for other drugs such as TKI inhibitors, as Bruno has just shared with us. And the most interesting thing for me is that there is a subset of patients who achieve a response which is really, really prolonged. The median duration of response exceeded 3 years, which is, for me, outstanding. And the median progression-free survival for the whole cohort was 7.4 months. So even if this is just a phase 1, and these data are, of course, preliminary because there is a few number of patients, the results from this is really, really promising. Interesting also that even a patient with, well, we should review this grade 1, but probably it wasn't a grade 1, but also achieved a response. And as you can see in this table coming from the same study, the safety profile of the drug is quite good. The majority of adverse events described were low grade. Some GI toxicity with diarrhea, nausea, and constipation, and some fatigue. But overall, this is a very well tolerated drug. The dose selected for further development was 500 milligrams per day. And currently, as I said at the beginning, there is a phase 3 study, the CONQUER study, which is a phase 3 against placebo that aims to demonstrate the activity of ivosidenib and going for registration, hopefully, of this drug in this disease. This study is currently being developed in 16 countries from CELNET. We have Brazil, France, Italy, and Spain and the US with the study open. Specifically in Spain, we have 7 centers open. Our center is actively recruiting patients, and this study. This is the design of the study. This is a randomized 1:1 to ivosidenib or placebo. Eligible patients are patients with conventional chondrosarcoma, so the differentiated chondrosarcoma patients are not allowed in this trial, but grade 1, 2, and 3 conventional chondrosarcoma can be included. Of course, patients have to have, the inclusion criteria I have in a later slide, so I will explain it later. The target of the study is to include 156 patients with more proportion of grade 1, grade 2, and there is also a subset of grade 3 patients. Initially there were 20. There is an ongoing amendment to increase the number of patients with grade 3 chondrosarcoma from 20 to 40. And the primary endpoint is progression-free survival by independent radiological review. Randomization is against placebo, but crossover is allowed after progression in the placebo arm. Other secondary endpoints, PFS, overall survival, and of course, this is overall response rate, quality of life, etc. So as I said before, only patients with conventional chondrosarcoma can be included in this study. They have to have advanced disease, can be locally advanced, non-resectable and non-curable, or metastatic disease. Currently, the study allows a maximum of 1 prior systemic treatment line for those patients with a grade 1, grade 2 chondrosarcoma, and 2 prior lines for patients with grade 3, but the amendment, which is ongoing, will allow 2 lines of previous therapy for every patient. And of course, patients have to have IDH1 mutations, which has to be demonstrated by central testing, even if the patient has a local positive testing. The central testing has to be repeated. And as in other studies, measurable disease and confirmation of progression has to be demonstrated before randomizing the patient in the study. Exclusion criteria are quite similar to other studies. The most important ones is that obviously previous therapy with another IDH1 inhibitor is not allowed. But interestingly, the ejection fraction needed, it's 40. Very frequently in clinical trials is 50. In this study it's 40, which is good because it's more flexible, and we are treating adult patients, some of them with other comorbidities. So this is good to my eyes because it allows more patients to be included. So this is the patient journey. The patient can undergo pre-screening. This pre-screening, it's optional, but it's very interesting because it can be done at any point. So if you have a patient with metastatic disease, even if it's currently being treated with other line, it can be pre-screened for this study. And because we have to demonstrate the IDH mutation. So as it takes a little bit of time, it's good if we go on with this pre-screening for all the potential candidates to have the information ready for the moment in which the patient go in progression. Then the therapy, as I said at the beginning, the drug is oral. It's taken once a day, and the cycles are every 28 days. The first cycle has several weekly visits, but after that, just the first day of the cycle, the patient has to come to the clinic. So it's quite easy in terms of visits and everything. So as said before, the pre-screening is not mandatory, but it's highly recommended. So all patients have to perform the IDH genotyping, but it can be done at the time of screening or as a previous pre-screening, which is the recommended thing. And a very interesting thing is that this pre-screening can be done through by video teleconsultation. So it's possible to have the pre-screening for patients not in your clinic, which is very interesting, and I will go in further detail in the next slide. And the compromise of the lab is to have the results from the central testing in around 15 working days from the moment they receive the sample, so to avoid undesirable delays. So there is a program to allow cross-border access to the clinical trial in Europe. So all patients, for example, from Portugal that will like to come to Spain are very welcome for this study. This is, of course, an opportunity for patients because currently there are very, very few clinical trials in which these patients can be enrolled. And as you saw before, the data from the phase 1 is quite promising. It's not a very difficult trial in terms of burden of visits, because they just have to come once a month, and there is reimbursement for traveling and everything. So it's a very nice opportunity for patients. So as I said before, this pre-screening can be done through a remote visit, so they don't have to come to the center. They just have to send us the ICF signed plus the block, of course. And if the patient presents an IDH mutation, they can be enrolled, and then of course he or she has to come to the center. So this was just to let you know the opportunity of this study. In case you have any candidate, you can directly write an email to me or to my colleague Carlos, and we will be very happy to evaluate the patients. And yeah, happy to answer any question in the discussion now.
Thank you, Nadia, very clear. And now the floor is open to question. And I also recommend to anybody in the chat, if they want to address some question, we will be happy to read them loud. But yeah, I can start actually, since you just finished, Nadia, with a question on the IDH mutation, which are requested for the ivosidenib trial. I wonder how frequent, if we know how frequent they are in comparison for the mutated, because yeah, the mutation is already below 50% of the patients. So I think I wonder if they might represent.
You mean the specific mutations that are
The
allowed?
specific as compared to the overall in mutation, and also at ESMO last year, already published, there was an interesting paper by the group of Padova, Professor Ruggeri, and they found prognostic value in some of these mutation. I will put the paper in the chat, just provocative. I don't know. I mean, it was very, very small, but still, I think the more we collect these patient data, the more we will learn.
Yeah, exactly. That's why I put it's still unclear. I think I put like as far as we know, it's not prognostic, but it doesn't mean that it's not prognostic. It does mean that we don't know. So probably with bigger series, as you know, as you said, we will have more clear a more clear photography. And this is, for example, this is an opportunity for CellNet, because we have the registry. We could try to make an effort to collect blocks and to do such kind of analysis to see the prognostic value of IDH mutations. With regards to the subtypes included, I don't have the exact data, but I guess these are, of course, the most frequent mutations. So I'm pretty sure it's more than 80% of the whole IDH mutations that is able to be included in the study. I don't know if I answered your question.
Thank you. And I put Trovarelli et al. Paper and the mutation that there is also Marta Sbaraglia in this paper, and Atos, and it is R132. So one of the one that are eligible, and actually is the most frequent.
Yeah, exactly.
But I think it's very interesting to look at the type of mutation, because it's arbor a different patient selection. Thank you.
So Dr. Brotto raised a hand, but then it go down. I don't know if you still have the question. If not, then Dr. Abreu.
Yeah, thank you, Marco. No, just my question was more general. So this is the reason that I retired the raise hand. Then after I will give a question. Thank you.
Okay. Dr. Abreu.
Hello, everyone. I have questions. The first of all is for the colleague that talked about Ewing sarcoma, because as you know, we have now more idea about this entire family that are not completely equal. And sometimes in the clinic, it's rare, but we have adult patients with BCOR associated tumors that relapse only locally. What to do in these situations? We can skip high-dose chemotherapy in the relapse and only perform surgery. What is your thoughts about that? We'll try a less intense regimen because it is a local relapse. What do you think about that? And the second question is for Nadia or Bruna, related to chondrosarcomas, because we have a special subtype that is an extraskeletal one. And so in these situations, do you think that our approach should be exactly the same as the skeletal one or not? Thank you.
Thank you, Miguel, for the first question about Ewing sarcoma. I have a patient with the same problem, locally aggressive and no metastasis disease, and regrow with the interval of chemotherapy delayed. And the indication in that case is intensify the local treatment with radiotherapy as neoadjuvant to surgery or after that. But I don't know if Emanuela have patients like that or another recommendation in 6
So,
Dukes.
yeah, thanks for the question. I think they are very different because I mean the survival in the graceful is more than 90%. So I wonder this patient had the positive margins. So my indication is always look for wide margin even with amputation and yes, I'm not convinced that he would need a systemic treatment. Probably in the lack of data, maybe you can try a couple of cycles with I don't know any of the Ewing, but the prognosis of BCOR is extremely good. So I will try some treatment, but the margins are the paramount for this kind of tumor. For the CHICDAX4, in my long experience now, I think that the most important is staging them continuously and cheesing the metastasis with radiation therapy because they are super radiosensitive. And yeah, they're like, we have a patient I would never forget because it's the first patient of the prospective trial who came to us with 4 metastases and 2 kids. I was so sorry for him and soft tissue metastasis, and then responded. The metastasis responded, radiation therapy, and then at the no, a complete response also on the lung. And then when at the end of the treatment, minimal progression, radiotherapy, and then again reprogressed of treatment, and we performed temozolomide irinotecan. In the graceful database, we have 11 patients treated with the temozolomide irinotecan, 0 objective response rate, which is unlike Ewing, but then again, this patient was treated combining radiation therapy again. And this is still alive after 4 years. So I think that it needs a very, very multidisciplinary approach and strong belief. And now I'm curious about the possibility to combine actually short course trabectedin and temozolomide irinotecan in these entities, because the trabectedin is a transcriptor regulator, and then thanks to the work of Patrick Goar in Ewing cell, but not in all these entities, we know that the length of the infusion it's paramount. So I think in the future we might have more potential combination, especially with lurbinectedin and trabectedin in this population. But yeah, we need we need to collect the cases, so join the Graceful registry. Now it's up and going, and we created working groups. There was a deadline, which was today, but then Australia had a technical program, so we will see if we can make an abstract. But what I want to collect is especially the treatment, because then when we chat here, I know what to tell you rather than 11 cases. I want all of our cases and then make a meaningful like phase 2 retrospective data on a specific drug, so that everybody will know how to speak with this patient.
And with regards to the question on extraskeletal myxoid chondrosarcoma, Miguel, this is a soft tissue sarcoma. I mean, it's a different entity. We know that they are exquisite sensitive to anti-angiogenics, and we developed the first prospective study in this disease, the HASTE 32 study, and we tested the activity of pazopanib in first and further lines in extraskeletal myxoid chondrosarcoma. This is a Lancet Oncology. I can share the paper on the chat. So we usually treat these patients with anti-angiogenics with pazopanib. Sometimes after progression we shift to another anti-angiogenic because there is sensitivity to more than one line. There is some data, also retrospective data on anthracyclines. Well, they might have some sensitivity to, well, not sensitivity, but they might modestly benefit from anthracyclines. But after, we always propose TKIs in first line. So chemotherapy is a further line. This is an entity which is also quite sensitive to radiotherapy. So when diagnosed localized, we always add radiotherapy to the surgery. And even in the metastatic setting, sometimes I think we have treated any patients with trabectedin plus radiotherapy, which can be also interesting in extraskeletal myxoid chondrosarcoma. And we have also data from a cohort from the immunosarc study that we presented last year at ASCO. It was sunitinib plus nivolumab. The limit of that cohort is that we don't know, it was just an arm, we don't know which of the activity that we saw was due to sunitinib and which was to nivolumab or which was for the combination. So, but in any case, also we observe activity with that combo.
Okay, thank you. It is the same like ours. Thank you.
I have.
Dr. Broto has raised his hand again, and then
Yeah. Sorry. This is a question for everybody, for every speaker. And by the way, congratulations for the effort in this update. So my question is, what do you consider is the best main endpoint for clinical research in these bone tumors? Is PFS, or rather do you think that it's better to consider overall response rate? What is your thoughts on that?
We should start.
Maybe
I can start. Dr. Palmerini had a huge experience of that with the use of TKI years before, because, for example, in osteosarcoma, the RECIST criteria don't work so well that in another tumors. Maybe, for example, in osteosarcoma, the rate of PFS at some time, at some point, is a good endpoint and was used in the previous TKI studies. Dr. Palmerini had the experience of that. But I think it's better. But how to measure the progression? A new lesion or or increase of the dimension of the previous one? I think maybe the new lesions will be better than only see the dimensional size of one of them. I don't know, Dr. Palmerini, your experience in your
I
studies.
I agree that progression-free survival is the best. Actually, I have to thank you, the Foster Consortium, and actually the young investigator there. And I think that yeah, we are open also always to collaborate. Relof, it's a Dutch pediatric oncologist. They did an incredible work of review of all the studies and set the hypothesis for PFS H1 and 0 according to all the previous benchmark studies. I will put you in the chat. I think that it's pretty clear that it's more pretty clear with the scant number and the heterogeneous population, but I think it's a huge work the team did to have that the collective validation. So I think that the CellNet, in case we want to run any trial, I think we might use that benchmark as an hypothesis. The most used, it's the Langmani study in 2012 because it's very convenient. Langmani took altogether, all the study, and the progression-free survival was only after 4 months, 12%. So the number of the patient, it's really low. So it's, but yeah, now we have 2012 and 2023 papers in the same direction with number deeply, sadly, very similar because there's no active, very groundbreaker drug, but a little bit of improvement. I will put both paper in the chat so for your to read. Thank you.
So Nadia, you have a question?
Yeah, I had a question, but quickly to add on this last question, which is very interesting. Also in osteosarcoma, sometimes we see recalcification of the lesions. This is another thing that it's not usually measured by any current criteria, but this is a kind of activity that we should measure somehow. I don't know which is the best way, but we saw many patients that we see even with increasing lesions, and we say he's in response. So there is really a challenge in the evaluation of response in bone tumors, because sometimes it's even more challenging than just looking at the size. It's also a question of density. I don't know if it a sort of retro Choi criteria, or I don't know how to call it.
I think, we should actually embark with the radiology in this discussion. Would be nice. There were recent guidelines by the radiology team at in Foster, but not talking about the calcification in the metastasis. I think it's very interesting. And actually, it's a pathological point of view. Dr. Rosenberg, we had an endocrine tumor of the lung, and there was the differentiation in osteosarcoma. And in the last sample, and he made the point that the liver metastasis was all bony calcified, as for him, an indication that was not more endocrine and the differentiated endocrine, but more sarcomatous lesion. So I think calcification is really into the behavior of sarcoma, and we should study that better.
Mm-hmm.
And also most of patients get better clinically. And also that's like a sign that maybe the treatment is working also, but it's not so specific as you can see on images. Then I think that Andres and Bruna can say something about answering Dr. Broto's question, and then we move forward.
Yeah, in Ewing sarcoma is more clearly that systematic reviews recommend PFS as a primary endpoint if you see the relapse or refractory Ewing sarcoma. For the problem, to 70% of the trials, phase 1 and phase 2 trial, use overall response rate, and this not correlate with survival.
Yeah, just to add what Marcos was saying about quality of life and patient-reported outcomes questionnaires, it's very important to highlight that we usually do not evaluate that, and you should, because sometimes clinical response is not corresponding to images, as Nadia just mentioned a lot, like the system that we're using to classify those. So it's a very complex situation, and especially for rare diseases where statistics are very much more difficult to calculate in the end of the day. It's interesting to put all those data together to understand better the direction of the disease. I know that MCBS is making an effort to include quality of life in the trials from now on. So I think you should evaluate better that to understand if you have a benefit or not from the drug, not just the numerical data.
So Nadia, you raise your hand.
Yeah, this is another different question. I don't know if we have. I think we finished about the responses.
Dr. Broto, do you want to add something to your question, or do you think that there is anything more important to say about this?
No. It's perfect. I think I agree with them. Yeah, it was just to focus on the best way to capture the added value of the treatments that we are using in the advanced disease. But I think it's completely understandable that the best way is PFS, maybe PFS at 4 months for osteosarcoma in second lines is most used, but depends on the context. But PFS in any case it seems it's the best.
But I want to add shortly something. But it will depend also about the treatment, because if you see the ADC trials in the waterfall plot, you see some kind of response also in the CAR-T cells reports. Okay? Because before, with the conventional chemotherapy or TKI treatments, maybe the resist criteria don't work so well, but the Artemis trial, you see the waterfall plot, kind of response, duration of response, long lasting, okay?
Nadia, you want to add something?
Yeah, I wanted
to. Another thing, yes.
I wanted to ask another general question for the panel, because we have mainly discussed today about options in advanced disease, but in the localized setting, we seem to have reached a ceiling of 65-70% overall survival that it's there from, I don't know, 30 years, 25 years, I don't know. So what do you think we can do? Well, in addition to
we already exceeded that with
the
addition of mifamortide, but we don't know if P-glycoprotein was favorable in this population, so we cannot say that. But you're right, yeah, we need more.
So do you think that we are going to translate some of these emerging therapies to the localized setting, or what do you think is the future to improve the overall survival, to improve the rate of patients cured, I would say? What do you think is the way?
For me, maybe yes. Now is recruiting the study of cabozantinib in adjuvant setting. I don't know with the Uramos protocol, but the new treatment that I thought maybe in the CAR-T HER2 directed therapy, there are 1 or 2 localized osteosarcoma treated with CAR-T. Maybe it could be used in frontline setting. Adding to Uramos protocol, I don't know, because ADC with chemo in another tumoral settings like breast cancer is combined ADC plus chemotherapy sequentially. But I don't know, maybe Dr. Palmerini designing clinical trials against
I just wanted I just wanted to tell again how not original we are, because in this moment 1,700 osteosarcoma localized patients will be randomized to cabozantinib MAP and then cabozantinib in the COG study, and it's ongoing, the Foster Cabo. Sorry, the other way around. The American, they combine chemo and cabo at the same time, while in the Foster Cabo, so it will be sequential. So we will see that other agent in the future. I think the floor is open. It's very complicated because, for example, we combine in the Foster Cabo or patient already receiving mifamurtide. Nobody want to give patient less than what approved. So again, the teams are the population is very heterogeneous, and actually for the first time it will enroll also Joe osteosarcoma, so another compounder. 10th study is randomized. But I think that I am really eager to see more in the space of radiotheranostics. I don't know how toxic and those are, but I would be intrigued to see those. We have also a study with radiotheranostics and the LLRC 15 in the phase 1 programs for all solid tumor. So I think that all surface molecule are upcoming. I think it might be something that toxicity, cost, and the complexity of designing an adjuvant study. I am not sure I will be here discussing the result, but let's see. Definitely we should break that 70% the ceiling.
Okay, any other comment or questions?
There are several trials that in Ewing sarcoma try to include TKA in the backbone scheme as maintained or parallel, and they don't have a huge benefit, and only talk about regorafenib, and we have more experience than another TKA with less toxicity and better outcomes like cabozantinib, like pazopanib. Maybe choose a better TKA could be a benefit.
So to address this question, I can speak. Paolo Berlanga presented at ASCO 82 milligram regorafenib combined with VDC in the Euro-Ewing study. So the question will be randomized and is the most exciting. And you're right, there are several TKIs and maybe regorafenib is not the best, but when you discuss about bone pediatric and rare tumor in general, it always go down to which compound will be available from the sponsor. So I remember that the discussion went on forever on the for example, ponatinib or other TKIs, but it's a good point. We should try to translate and put in our trials the best rather than the most convenient.
Because I think it's important also to highlight that in this context, in bone sarcomas especially, the academic clinical trials are the most important part of the research. So that's why many of the designs are very pragmatic. Sometimes the drugs are not the ones you would like to have, but it's what you have achieved. So that's an added challenge in the research of these diseases, that sometimes we don't have the budget, we don't have the drug, but in any case, what Euro-Ewing program has done, for example, in the last decade, it's amazing because it has defined the first and the further lines of Ewing sarcoma. So we have to make everybody aware of how worth academic research is.
Yeah,
Indeed.
academic and also adaptive design should be absolutely the future. Sorry,
No, just a quick comment. I think this is a good opportunity for CELNET institutions because, for instance, in osteosarcoma, we try to activate a chemoimmunotherapy trial, phase 1/2 trial, in those patients with metastasis at presentation. And in this sense, Michael said that 70% of cases that are diagnosed in his institutions have metastasis at the presentation. So I think it's a good opportunity to explore this chemoimmunotherapy because two of the most important inducer of immunogenic cell death are platinum compound and anthracyclines, which are the backbone of the osteosarcoma first line. So I think in the metastatic setting, when the primary tumor is resectable, is the best scenario to check the chemoimmunotherapy in osteosarcoma. And then maybe in some institutions of CELNET, this could be performed. Maybe when the PD-1 inhibitors will be generic, I don't know. But this is very, very appealing and very promising strategy because I think this is important. And this concept is not new, but is working, the chemoimmunotherapy synergistic action. So, and the same could be applied for the differentiated chondrosarcoma as well. So I think this is, for me, the most attractive way to increase the ceiling effect of 65% of cure rate in the osteosarcoma, for instance. But yeah, TKI also is promising, but I think I am more believer than in chemoimmuno than in
Thank you,
TKI.
Javier. Here in the United States, they prescribe immunotherapy like, oh my gosh.
I know.
I mean, if you believe it, I could start tomorrow to do in all of my patients.
I know. But in any case, we should explore this in a prospective way within clinical trials.
Maybe let's collect our cases, but it's gonna be super easy. You don't realize, especially my end, but I don't know. Thank you. But anyhow, it's already 3 minutes past. I think we should close the floor. It was super interesting and brilliant talks. I really enjoy listening to them. And I love this community, so please reach out for anything, and I always hope to see you in person soon.
Bye. Thank you very much.
Bye.
Bye.
Bye. Take care.
Bye.
Bye. Bye. Thank you.